Okay, so moving down to the knee joint. The knee joint is the largest joint in the human body in terms of surface area, synovial membrane, and it has three articulations. There are three bones to describe when describing the anatomy of the knee joint. There is the femur, the tibia, and the patella. The junction between the femur and the tibia is often called the tibiofemoral joint, and the junction between the patella and the femur is often called the patellofemoral joint. It is classified as a synovial bicondylar joint. It is actually two condyloid joints with a synovial saddle joint in between. So the patella and the femur form a synovial saddle joint, and the two condyles of the femur form two condyloid joints with the two condyles of the tibia. Some texts will describe this as a synovial hinge joint. It cannot be strictly speaking a synovial hinge joint because it has two axes of rotation. The knee joint can flex and extend, and with the flexed knee it can actively medially and laterally rotate. So therefore it cannot be accurately classified as a synovial hinge joint. Rotation can only occur physiologically, in other words under volitional control, when the knee is flexed. Rotation does occur as an accessory movement in the knee. So as we move from a flexed position to an extended position, the tibia will externally rotate in the terminal phases of knee extension. This is a mechanism known as the locking mechanism and is brought about by tension in the ligamentous structures. Okay, so when describing the articular surfaces of the knee joint, there are three articulations that need to be described: the medial and lateral tibiofemoral joints and the patellofemoral joint. When we talk about the femur, what we have here is we have an image of the underside of the femur. This is the lateral condyle over here. This is the medial condyle. This section in the middle is the patellar surface. So this is the bit where the patella articulates and sits. This is an inferior aspect, so this is looking at the patella from the inferior aspect. So up here we've got the anterior portion. At the back here we've got the intercondylar space. The medial and lateral femoral condyles and the patellar surface in between them are differentiated by a faint ridge. Yeah, so there is a ridge along here and there is another ridge along here. This ridge is formed by the tibia reaching its terminal position in extension. So the tibia will only articulate with the condyles. The tibia does not move around, or the tibia does not come around to this surface here. The patella, on the other hand, when the knee is in full extension, the patella will sit on the anterior aspect of the lower part of the femur, and as the knee moves into flexion, the patella moves down into this groove on this sellar surface and may actually encroach down. If we go into full flexion, it may actually encroach down on the inferior aspect of the two condyles as well. The whole articular surface, the two condyles and the patellar surface, is covered in hyaline cartilage, just like any other typical synovial joint. And the hyaline cartilage is continuous. Although we talk about the tibial surfaces versus the patellar surfaces as being different areas, it is one continuous layer of hyaline cartilage. Another point to note is that the concavity of the patellar surface changes from proximal to distal. It's actually quite significantly flatter on the superior aspect, and it's much more concave on the inferior aspect. This has an effect on the stability of the patella when the knee is flexed, when the knee is in a flexed position. When describing the femoral condyles, there's a couple of points to note. They are both biconvex. In other words, they're convex in the anteroposterior plane and in the mediolateral plane. They are different in shape. This is the lateral condyle over here, and the lateral condyle is typically shorter, rounder and stouter than the medial condyle. The medial condyle is longer and thinner. So here we can see this is the medial condyle, and we can see how it's like an elongated oval, whereas this is a shorter, rounder oval. And in addition to that, the axes of the two condyles themselves are such that they converge anteriorly. This is important when we come to discuss the locking mechanism of the knee. This is important because the shorter lateral condyle means that the lateral lateral tibial condyle will reach terminal extension before the medial tibial condyle does, and as a result of which we end up getting this external rotation, this lateral rotation occurring in the terminal phases of extension, the locking position that was mentioned earlier. When looking at the femoral condyles from a lateral view, there is a variation in the radius of curvature of both condyles. Okay, and this is so in other words, the actual condyles themselves are not perfectly spherical structures. This is the medial condyle that looks slightly more rounded than the lateral condyle, but the anteroposterior plane of both condyles is longer than the vertical plane, so consequently it's an elliptical structure. This has implications of the axis of rotation of the knee joint itself. So when the tibia moves from an extended through to a flexed position, the axis of rotation will change, it will vary. So when the knee's in full extension, the axis of rotation sits approximately here. As we move to flexion, we can see this is the axis of rotation, and as we go into full flexion, the axis of rotation actually sits really quite posterior. Okay, so in terms of measuring motion at the knee, we've got to be aware that we have a variable axis of rotation rather than a stationary axis of rotation. The patella is a sesamoid bone. It's a triangular shaped sesamoid bone, with this section down here, the apex being the inferior aspect of the patella. This is the base. Okay, now the patella is a sesamoid bone that sits in the tendon of the quadriceps muscle. It's the largest sesamoid bone that we have in the body, and when we take a patella and turn it over, look at the posterior aspect, what we see is an articular and a non-articular portion. This blue area that we can see on this diagram is the articular portion, and the apex down here, is the non-articular portion. The apex sits buried in the tendon itself, whereas the articular portion is the section that articulates with the anterior aspect of the femur. The articular portion is divided up by a central ridge into a smaller medial facet and a larger lateral facet. Depending on which text you read, the posterior aspect of the patella, the posterior surface of the patella, is often subdivided into more facets. So on the medial side, you'll hear people talk about the medial odd facet, which is a small facet that sits over here, very subject to, or very prone to, degenerative changes, and then the rest of the medial facet and the lateral facet is sometimes further subdivided into a superior, middle and inferior component. The two facets are divided by the large central ridge here, and the central ridge, as we move from an extended to a flexed position, the central ridge drops into the groove between the two femoral condyles, and this gives the patella stability. So when assessing for mobility or stability of the patella itself, it's best done with a knee in full extension, as when the knee moves into flexion, because of the bony architecture of the patellofemoral joint in flexion, you'll get very little movement. Also, clinically, from a mobilization point of view, if ever we want to mobilize the patella, get the patella gliding medially and laterally, this is best done with the knee in extension. The articular surface of the patella is covered in a thick layer of hyaline cartilage. The hyaline cartilage is thickest over the central ridge, and the hyaline cartilage on the back of the patella is the thickest cartilage that we have in the body. The hyaline cartilage on the posterior aspect of the patella is very prone to degenerative changes, to softening and to fissuring, and patellofemoral joint dysfunction is a very common pathology that is seen by the physiotherapist or the rehabilitator. Moving down onto the tibia again is classified as a long bone. It's the superior aspect of the tibia that we're interested in when it comes to looking at the knee joint itself. This is a picture looking at the superior aspect of the tibia. This is the anterior portion here. This is the posterior portion down here. The patella, the superior aspect of the patella, is divided into two condyles, which are covered in hyaline cartilage. We've got a longer, thinner medial condyle and a shorter, fatter, rounder lateral condyle. The two condyles, the superior aspect of the two condyles, are covered in hyaline cartilage. In between the two condyles is a section known as the intercondylar eminence. This is deficient of hyaline cartilage. This does not form part of the articular surface at all. Instead, what we see on the intercondylar eminence is we see various structures attaching there, structures such as the posterior cruciate ligament here, the anterior cruciate ligament, the horns of the two menisci will attach onto the intercondylar eminence. But this does not form part of the articular surface. So therefore, even though it sits within the boundaries of the joint capsule, the intercondylar eminence is kept outside the boundaries of the synovium. So it's intracapsular but extrasynovial. Point to note is that the shapes of the condyles themselves differ from the medial versus lateral side, and they reflect the shape of the femoral condyle. So where the medial femoral condyle is longer, narrower and obliquely orientated, the medial tibial condyle reflects this shape. When looking at the tibia from the lateral view, first thing that we note is we notice that the medial tibial condyle is biconcave. It's concave in the anteroposterior plane and it's concave in the mediolateral plane. The lateral tibial condyle, however, is concave in the mediolateral plane, but is actually either flat or slightly convex in the anteroposterior direction. This has implications for stability. The medial tibiofemoral joint is inherently more stable than the lateral tibiofemoral joint. The lateral tibiofemoral joint is like it's akin to balancing two balls upon each other, whereas the medial tibiofemoral joint is more akin to balancing a ball on a saucer. When we look at the joint capsule of the knee joint, it's a relatively simple joint capsule. It passes beyond the articular margins medially and laterally down to beyond the articular margins lower down on the tibia and fibula. So here we've got the capsule passing from the lateral femoral condyle above the groove for popliteus, extending right down here to the head of fibula and to the tibia. Posteriorly, it does the same thing. It goes just beyond the articular margins of the femur at the top to just beyond the articular margins of the tibia down below, and medially it does the same thing. Anteriorly, there is no capsule. The anterior aspect of the capsule is replaced by this structure here, the extensor mechanism, and the extensor mechanism includes the patella, the tendon of the quadriceps and the ligamentum patellae here, and the expansions, small expansions of the patella tendon itself, the patella retinaculi. The capsule blends into this structure, so the knee is still a sealed unit, but the true capsule only exists medially, laterally, and posteriorly.